In our talk, we described problems with our comfort care order set at our institutions and how that order set came to be. And so we talked about the history of providing comfort care in hospitals and creating order sets, and then paralleled that with ICU care and the changes in ventilator withdrawal and caring for patients in the ICU. And we talked about how really the old ICU and ventilator withdrawal models of using opioid infusions.
A lot of comfort care order sets have a lot of just kind of standard orders that people order, and there's not a lot of guidance around those. Especially we work at teaching hospitals, and we have a lot of young physicians, new residents who don't really know how to order or when to order, who needs an infusion, who doesn't. And so the other big part of our project was also creating an opioid decision tool that we call our opioid decision tree, and that actually kind of walks them through what makes sense for my individual patient in front of me.
Having opioid infusions for comfort care order sets that are really more in line with pharmacologic principles and what more and more experts are now recommending. The way that we did this within our order set was opioid decision tree, as Caroline mentioned, and also we have opioid infusion algorithms for morphine, hydromorphone, and fentanyl. And for these infusion algorithms, they're for nurses to be able to intensify treatment for patients with uncontrolled symptoms, and to be able to do that in a stepwise fashion. And for these algorithms, the nurse can go up on the opioid infusion dose every 8 hours, as opposed to our old order set, which was every 30 minutes. Also, we are really focusing more on bolus doses and being able to give more frequent boluses. And the bolus dose is a percentage of the infusion dose, depending on what dose the opioid infusion is at. And that percentage goes down as the infusion dose increases. And the reason for that is that at higher doses of opioids, there's higher risk of having toxic metabolites build up, resulting in side effects that cause more discomfort. If I were to summarize the pharmacologic principles that we incorporated into the algorithm, one would be to titrate the infusion closer to steady state. And the next would be for the IV boluses in between those titrations. We wanted that to mirror the peak effect, which is around 10 to 20 minutes. And then finally, we wanted to be able to increase the PRN bolus doses every half an hour to 1 hour.
The summary, I think, for algorithms is that these are based in pharmacologic principles, and we've kind of lengthened the time of opioid titration of the infusion, but we've allowed for more liberal bolusing in the meantime. And I think the other big thing that we did that I would say as a summary, as a takeaway, is in terms of ventilator withdrawal, is really thinking about ventilator withdrawal as an isolated procedure with around a short time period, kind of within the several kind of hours right around ventilator withdrawal, and just really using bolus dosing. Infusion maybe as an underlying continuous infusion that just gets baseline symptoms, but really acute symptoms are for bolusing during that time period. And we've kind of isolated that time period as being different than the rest of the comfort care piece.